Hi everyone, welcome to Hub Bites. I'm Sunil Rege, consultant psychiatrist. If you're new to this channel, we cover all things psychiatry and mental health related. So if that's your thing, don't forget to subscribe to our channel. Today I'll be talking about antidepressants. Take you through the range of antidepressants, providing you an overview of the main mechanisms of action and really how to think about antidepressants targeting specific symptoms sort of based on their mechanisms of action. Now, when we think about antidepressants, we often tend to think about them as a single entity, but they're actually not. They have different mechanisms of action, and some of the mechanisms of action, we don't even know how they work because there's more data coming out, fascinating data as to what they might be doing. So I'll take you through some of those things. So let's jump into it and check out what are antidepressants. Now, antidepressants as a whole are medications that can help relieve symptoms of depression, social anxiety disorder, anxiety disorders, seasonal affective disorder, dysthymia, mild chronic depression, as well as other conditions. For example, in eating disorders, they're indicated. In PMDD, they're premenstrual dysphoric disorder, they're indicated, etc. So, interestingly, if you think about it, fluvoxamine in COVID-19 has shown some benefits in reducing hospitalization, reducing severity. So what that sort of tells us is we talk about antidepressants as a very simplistic term, antidepressant against depression. But when we think about the molecular effects and what we know and what we don't know, there might be a lot more going through. So let's see what more can we learn about it. Antidepressants were first developed in the 1950s, and their use has become progressively more common in the last sort of 20 years. And there's often a big debate as to whether, more antidepressants are prescribed individuals, whether that's due to easy prescribing or whether the incidence of depression has gone up. And those are things that, are difficult to really understand overall. So we won't go into those details in this particular video. Now, what are the types of antidepressants? So if we think about broadly the armamentarium that a clinician has, we have the SSRIs, which are the selective serotonin reuptake inhibitors. We have the SARI, which is a serotonin antagonist reuptake inhibitors, such as trazodone. SSRIs are fluoxetine, fluvoxamine, sertraline, escitalopram, citalopram, paroxetine, and these, of course, have their own trade names across different countries. SNRIs, which are serotonin noradrenaline reuptake inhibitors. Now, both SSRIs and SNRIs, we've done videos on this channel, so do check that out to sort of have a deep dive into these medications. Now, SNRIs are desvenlafaxine, venlafaxine at higher doses greater than 225 milligrams, milnacipran, duloxetine are SNRIs. Then we have NASA, which is a noradrenergic serotonin specific antagonist. So they block certain specific serotonin receptors, but they also increase levels of noradrenaline through specific pathways. And this is agents such as mirtazapine and mianserine. Then we have agomelatine. These are novel antidepressants. Agomelatine will see melatonergic activity, but also increasing frontal lobe dopamine. Then we have vortioxetine, which is a serotonin modulator, but also has multimodal effects by increasing histamine, acetylcholine, dopamine, etc. Then we have this sort of group, tricyclics and MAO inhibitors, tricyclic antidepressants, tricyclic, so they actually increase amine levels, all three. So serotonin, noradrenaline, dopamine. So obviously in the more severe end of the spectrum is where we use them. MAO inhibitors are monoamine oxidase inhibitors. So monoamine oxidase is an enzyme that breaks down serotonin, noradrenaline, dopamine, and MAO inhibitors are ones that prevent that breakdown, so you get elevated levels of those amines. Then we have NDRI, which is noradrenaline dopamine reuptake inhibitor, so increases levels of noradrenaline dopamine, such as Bupropion. And then we have NARI, which is a noradrenergic reuptake inhibitor, which is such as reboxetine, right? So you can see that not all antidepressants are the same. And based on their mechanism of action, their profile, their tolerability, side effect profile is different, and their efficacy profile is also different. Now, we talk about antidepressants, but we can't afford to forget other agents, neurosteroids, hormones, and their effect on the brain as well. These are powerful antidepressants. So we know that try monoamine neurotransmitter deficiency in the limbic areas or even the frontal lobe is associated with depression. But we can't afford to forget that estrogen is an important neurosteroid that actually impacts on dopamine and serotonin levels in the brain. So it's linked to cognition and mood. When we talked about it in our video on PMDD, premenstrual dysphoric disorder, I've written articles on PMDD and menopause as well. And in these cases, we have to think about the role of hormones on the brain, right? They're very, very powerful agents that impact on brain function, on neuroplasticity, provide neuroprotection, affect cognition, behavior, mood, the whole lot. Thyroid is another really important one. In fact, the organ in the body with the highest number of thyroid receptors is the brain. Even though it comes under the realm of endocrinologists, the brain has the highest number of thyroid receptors. So thyroid plays a very important part as well. Again, I've covered an important article on psychscenehub.com on thyroid and how to think about TSH, because TSH levels when it comes to psychiatry needs to be thought about differently rather than in endocrinology. Because we often find that mood symptoms may occur at levels around 3.5 even, which is normal according to the test, right? So it needs to be always clinically correlated. I always believe, we're treating the patient, not the blood test. Similarly here, when we think about estrogen, it's important to recognize that testosterone is converted to estrogen. So testosterone is another one in males that we need to take into account. Low levels of testosterone are associated with depression. So basically, these three areas that I've talked about, these hormones, they enhance the receptor sensitivity for serotonin, noradrenaline, and dopamine. So by augmenting in certain cases, so for example, in menopause, there is evidence, perimenopause, there is evidence for estrogen augmentation of antidepressants showing benefits, right? Similarly, thyroid augmentation of antidepressants can provide benefits. So it's important that these aspects always need to be looked at. And you can see I've added the serotonin, neuron, noradrenaline, and dopamine. So the clinical utility of antidepressants. Now, I've kind of ranked it in terms of tolerability and efficacy, because ultimately all decisions that we make is a risk-benefit analysis as a clinician in a shared decision-making model. So we've got SSRIs, and you can see tolerability, efficacy. So there's good, reasonable efficacy. Tolerability is reasonably good as well. However, for some patients, they don't suit at all, because some patients can have weight gain, others don't. Some patients can have significant sexual dysfunction. Some patients have significant anxiety associated with it, emotional blunting. And of course, the withdrawal symptoms also need to be taken into account. We've done a video on that. Then NSAIDs, which is mirtazapine, meanserine. Again, efficacy, reasonably good. Tolerability, the weight gain aspect is something to take into account because they often have antihistaminergic property. Then, not to forget the melatonergic agonists, agomelatine, right? Very good tolerability and efficacy overall because, it does not have the antihistaminergic properties, so no weight gain, no sexual dysfunction, no emotional blunting. Really, really good tolerability profile. NDRI, Bupropion. Again, a pretty good tolerability profile. Why? No sexual dysfunction. In fact, is a treatment for antidepressant-induced sexual dysfunction. Improves, one of the few agents that improves libido and does not have weight gain, does not have emotional blunting. So pretty good agent overall. SNRIs, because it has the S component, we similarly get, as you can see, the tolerability profile can worsen a bit. Sexual dysfunction, emotional blunting can occur, but has a pretty good efficacy because you get noradrenaline, dopamine, and serotonin, all three amines up. NARIs, which is the reboxetine. Now, reboxetine sort of fallen out of favor, some used, mainly because it showed in a meta-analysis that it can affect liver functions adversely. But on the other hand, the efficacy is not as good as previously thought. Having said that, remember, what we see on a group level might be quite different to an individual level. So this is why clinical assessment, individualization of therapy becomes so important. And then we have MAO inhibitors as well. You can see in terms of the efficacy, tricyclics and MAOs really are higher up. You can see here much more than the others. because they are triamine. They increase the levels of noradrenaline, dopamine, and serotonin, as opposed to the others, SSRIs, which is predominant serotonin, maybe a little bit of dopamine. SNRIs, serotonin, noradrenaline, and maybe 0.5 of dopamine in a way, 2.5, I think about it, compared to tricyclics, which is 3, right? So this is how we're thinking about antidepressants as a whole. Now, you can see that there is quite a bit of complexity going through this, right? So, of course, I'm squeezing through this pretty quickly, but do have a listen to the SSRI and SNRI video to get that further knowledge, mirtazapine video for the NASA, where I go into this in more detail. Now, as a clinician, when a patient comes to us with certain symptoms, right, and we've diagnosed depression, it's predominant depression, we then think about the severity, mild, because for mild, antidepressants may not be needed. Supportive counseling, lifestyle changes, diet, nutrition, exercise, etc. may work, or behavioral activation, CBT may work, sleep hygiene may work, right? But when it gets to the moderate and severe ends of the spectrum, then we may need medication. So we tend to think, okay, what are the predominant symptoms and what antidepressants may match that? So generally, again, this is in general, when anxiety is present, SSRIs and SNRIs are evidence-based. You might recall in the video on generalized anxiety disorder, SSRIs and SNRIs tend to have good evidence. Then we have duloxetine and vortioxetine. Now, these are good agents when it comes to cognition, when there are memory complaints, problems with decision-making, learning. Duloxetine and vortioxetine can do well. If there are sleep disturbances, I'm thinking about melatonergic agents, agomelatine, which is an M1, M2 agonist, so promotes melatonergic activity, which we know is helpful in circadian rhythm dysfunction, and mirtazapine, because of two reasons. It has a 5-HT2A antagonism. 5-HT2A receptor is situated in the reticular activating system, the sleep area of the brain, so it promotes slow wave sleep. Slow wave sleep is the deep sleep. The non-REM sleep is the sleep that is necessary for neuroprotection, neuroplasticity, consolidation of memories. But it also has an additional property of antihistaminergic property, and we know that antihistamines can promote sedation. Sometimes this antihistaminergic property is a double-edged sword. It can promote sedation, but people can feel drowsy, groggy in the morning. And it's also associated with weight gain in some patients. Then we have bupropion, the NDRI. Now, bupropion is a very good agent in a few aspects, good tolerability, no sexual dysfunction, but it can target fatigue quite well. So bupropion can be one of the agents used in, say, chronic fatigue syndrome and depression. Bupropion is also combined in a new agent called Contrave with naltrexone for weight loss, right? Bupropion is also evidence-based for smoking cessation. So if someone wants to stop smoking, they have depression, bupropion can be used. So it's an NDRI, good to combat fatigue and the severe ends of the spectrum of depression. If pain is present, duloxetine is a good agent. Often higher doses are required because above 60 milligrams is where you start getting the prominent noradrenergic activity, which is where the pain pathways in the spinal cord are activated, the noradrenergic pathways in the spinal cord. And just like duloxetine, there is another agent called milnacipran, which is evidence-based in fibromyalgia, right? Pain, allodynia, heightened sensitivity to pain. So duloxetine is an SNRI, milnacipran is an SNRI, and tricyclics such as amitriptyline at low doses, 25-50 is often prescribed, can really help with sleep as well. As you can see, if there's melancholia, now, I've done a separate video on melancholic depression. Why? Because it's a different entity. It's a different entity that has a prominent biological weighting, right? We need to always break down the kinds of depression. And because of its predominant biological weighting, we need agents that have a higher broad spectrum activity. And tricyclics is one of them. So tricyclic antidepressants such as imipramine, nortriptyline, desipramine, amitriptyline higher doses are ones indicated for this kind of depression. Now, I've also done the video on psychotic depression, right? So if psychotic symptoms are present, this is so important. There was a research study called the STOP PD study, which is Stop Study in Psychotic Depression. And it showed that, firstly, 25% of patients are misdiagnosed because psychotic symptoms are missed. And only 5% of patients actually receive an adequate dose of an antidepressant and an antipsychotic. So this sort of depression is really, really missed and often can lead to disastrous consequences as well. So do have a listen to that video, because for treating this depression, we need augmentation with an antipsychotic. And often a low-dose antipsychotic is required, okay? We see in the video of antipsychotics, antipsychotics essentially reduce the dopamine in the mesolimbic pathway, right? So this is something I've covered in the video on schizophrenia as well on our channel. Then we have MAOs. MAO inhibitors are agents that increase, again, serotonin, noradrenaline, dopamine. So they're broad spectrum, right? And this can help with atypical symptoms when depression, there's phenelzine particularly, with hyperphagia, hypersomnia, atypical depression, it can be useful. So if we take a step back, I know it's a lot of information to take in, but essentially what it really tells us is that we need to understand firstly the mechanisms of action. We need to then understand how to target the mechanism of action to the appropriate symptoms. And at the same time, recognize that each person's different, therefore doing a risk-benefit analysis to maximize efficacy and maximize tolerability, which means minimizing side effects. So how do some of the commonly prescribed antidepressants work? Now, I won't go through SSRIs in more detail or SNRIs. Why? Because I've covered it. But essentially, SSRIs treat depression by increasing levels of serotonin in the brain. Now, this is a very, very simplistic sort of definition, by increasing serotonin. We now know that there is more to it. It's not just about increasing serotonin levels. So, serotonin is one of the chemical messengers that carry signals between brain cells. Again, very, very simplistic. They block the reabsorption of serotonin, which means they block SERT, which is the protein that breaks down serotonin. By blocking it, there's increased serotonin in the synaptic cleft. And simplistically, it makes more serotonin available, right? So they're called selective because they mainly affect serotonin. But we now know there is more to SSRIs than just serotonin. In fact, in 2020 or 2021, more recently, they discovered that antidepressants, SSRIs, SNRIs, ketamine even, tricyclic antidepressants, the common pathway may be through what's called the TRKB receptor, I'll show you later, which is the BDNF receptor. The BDNF is a fertilizer for the brain. It's a neurotrophin, which is brain-derived neurotropic factor, right? And neurotrophins are basically fertilizers for the brain, so they actually enhance synaptic plasticity. They enhance growth of synapses and neurons, etc. Note that there are 500 trillion synapses in the brain. It's a very, very complex organ, right? And to think that we have solved all of it, we aren't. So in psychiatry, we're limited with trying to find out more about it. But yes, we are limited with the treatments that we have. They're not perfect by any means, but there is more and more that we know. I've also written an article on the latest in SSRIs, and this is really fascinating. So SSRIs, besides this simplistic elevated serotonin, they actually modulate astrocytes. Astrocytes are really important cells in the brain, right? They're immune cells, but they have a number of functions in the brain: neuroprotection, neuroplasticity, and SSRIs modulate astrocytes, providing these additional benefits. So in neuroinflammation, astrocytes are affected. Cytokines can be released. So one of the things SSRIs also do is they reduce neuroinflammation. And one wonders whether that's one of the reasons why fluvoxamine was evidence-based in COVID-19 in reducing hospitalization and severity. And that happens through the sigma-1 receptor. Sigma-1 receptor agonism. So it's truly fascinating. So it's got reducing inflammation, neuroinflammation, modulating astrocytes, and there's more known about astrocytic function, microglial function in depression, and the third, increasing BDNF levels. And that might be a greater reason rather than the simplistic serotonin. Then we have SNRIs. Now, SNRIs, the way I think about it, they increase levels of serotonin, they increase levels of noradrenaline. So as you can see, affecting changes in brain chemistry, communication, brain, simplistic, okay? But they block the reabsorption of the neurotransmitter serotonin and norepinephrine. But as you'll see in the video that I've done in more detail, they also increase levels of dopamine, because why? The norepinephrine transporter, or the noradrenergic transporter, same thing, which is the protein that breaks down noradrenaline, also works in the frontal lobe for dopamine. So there's a little bit of dopamine increase as well. So you get serotonin, noradrenaline, and maybe say 0.5 of dopamine. So a way I think about it, it's a 2.5 broad spectrum antidepressant. Next, tricyclics, all three. It blocks DAT, dopamine transporter, blocks serotonin, SERT, and blocks NAT, noradrenergic. So you get increased serotonin, noradrenaline, dopamine, all three, tricyclics, right? So again, very similar. They help to keep more serotonin, norepinephrine. I'd add dopamine there as well. They're made naturally in our bodies. We know this through diet, etc. They also block the effects of histamine. The antihistaminergic property can promote sleep. You might remember that in sleep, it can be used, low doses. And this is one of the reasons why the side effects can occur: dry mouth, constipation, glaucoma. They also have what's called anticholinergic effects, and anticholinergic effects are more likely to lead to exacerbation of glaucoma, constipation, dry mouth as well, rather than just histamine. So you got ACH as well, which is acetylcholine. So by blocking the cholinergic effects, you can have these side effects. Okay, so that's tricyclic antidepressants. So this is essentially the newer data that we have. Antidepressants bind to the dimers of the TRKB, transmembrane receptor. So this is a transmembrane, this is a membrane here, right? And this is a transmembrane receptor. So by binding to this particular receptor, it facilitates BDNF signaling and neuroplasticity. So it basically enhances neuroplasticity. And interestingly, similar sort of actions have been found with psychedelics through these receptors, improving BDNF. Psychedelics are also associated with improving BDNF, psilocybin, for example. Then we have MAO inhibitors. So MAO inhibitors often specialized treatment. Why? Because dietary changes often need to be made. So again, brain chemistry, simplistic way of putting it, it's involved in removing the neurotransmitters norepinephrine, serotonin, and dopamine. So that's what monoamine oxidase, the enzyme, does, right? What these medications do is they block that enzyme. So MAOs prevent this from happening, which makes more of these brain chemicals available. And MAOs also affect other neurotransmitters in the brain and digestive system, causing side effects. So if we look at MAOs, for example, here, you can see, production of dopamine, metabolism of dopamine. It's a busy slide, but let me just point out important aspects. We can see that tyrosine, which is obtained from diet, gets converted by tyrosine hydroxylase to DOPA. DOPA gets converted by DOPA decarboxylase to dopamine. Dopamine then gets packed into vesicles and then is released, right? So that's how we get our dopamine. Now, dopamine gets converted to noradrenaline as well. Now, we've got two enzymes, monoamine A, oxidase A, monoamine oxidase B. Monoamine oxidase A converts noradrenaline into metabolites. Monoamine oxidase B converts dopamine into metabolites. So what you get is these pills block this, therefore increased levels of noradrenaline, dopamine here, right? And that is responsible for its mechanism of action, so increasing those neurotransmitters. Serotonin, MAO, we have MAO A receptor. The MAO A receptor eats up serotonin, right? So what do these agents do? They block this particular receptor. Lots of available serotonins there, moves into the synaptic cleft and activation of the postsynaptic neuron. So basically you get activity related to serotonin. With MAO inhibitors, one's got to think about what's called the cheese reaction or the tyramine reaction. Now, one, of course, needs a significant amount of, ingestion. This used to be much more common in the past. Why? Because much of the food used to be preserved, right? So say sauerkraut, for example, cheese that is aged for a long time. These things contain higher levels of tyramine. Diets change, foods change, so there's a lower incidence, but one always has to be cautious about tyramine reaction. And essentially that happens because, tyramine in the gut It's metabolized by MAO-A and MAO-B in the gut. And similarly, in the liver. So you can imagine what a MAO inhibitor does. If it blocks this metabolism, you have loads of tyramine in the blood. Now, when you have too much tyramine in the blood, this tyramine can cause problems. It results in what's known as a pressor response, right? Hypertensive crisis, etc. All right. So MAO inhibit the peripheral catabolism of tyramine, allowing tyramine to enter systemic circulation, and enhances noradrenaline release through its action on the TAR1 receptor. So this receptor. So basically, simple way this is a pressor response. Basically, tyramine should be broken down, right, through the MAO enzymes. MAO inhibitors block it, so loads of tyramine, and that's what causes the side effects, the pressor response. Okay, then we have NASA's. Do have a listen to that video that we've covered. It's different from SSRIs or SNRIs, completely different. So these have, they are serotonergic and noradrenergic antidepressants. NA stands for noradrenaline, serotonin specific antagonism. Okay. So what they do is, interestingly, they have alpha-2 activity. So by blocking the alpha-2 receptor, they can increase levels of noradrenaline, and they also antagonize these receptors, 5-HT2A, 5-HT2C, and 5-HT3. Okay, and by blocking these receptors, they have some positive effects, right? So 5-HT2A promotes slow wave sleep, reduces anxiety. 5-HT2C is the receptor for sexual function. So by blocking it, there's no sexual dysfunction. Mirtazapine can be a treatment for sexual dysfunction, and 5-HT3 is in the gut, nausea, vomiting, diarrhea. So by blocking that, it has anti-nausea, anti-vomiting effects as well. So you don't have those gut-related side effects. So you can see that it's quite a multimodal sort of antidepressant. Mirtazapine, meanserine. Melatonergic agonists, agomelatine, right? Analogs of melatonin that bind to and activate the melatonin receptor. Now, Melatonergic is another one that is used mainly for sleep. But in this case, agomelatine is the main one I'm discussing. They have a number of therapeutic applications for sleep disorders and depression. So sleep disorders, Melatonergic is the other one. The discovery and development of melatonin receptor agonists was motivated by the need for more potent analogs than melatonin with better pharmacokinetics and longer half-life. The melatonin receptors are G protein coupled receptors, and there are two subtypes, MT1, MT2. So agomelatine activates these two receptors. Melatonin and melatonin receptor agonists on the market or in clinic trials all bind to and activate both receptor subtypes. And when melatonin receptor agonists bind to and activate the receptors, it causes numerous physiological processes. So interestingly, the combination of M1, M2 agonism plus 5-HT2C antagonism, the combination is known to increase noradrenaline and dopamine. And that's why agomelatine tends to increase noradrenaline and dopamine, which are crucial in frontal lobe activity, attention, concentration, cognition, hedonic drive, experiencing pleasure, cognitive effects, right? All of the motivation, all of those aspects. Now, serotonin modulator, this is the Vortioxetine, right? So Vortioxetine, again, a very good agent, lower incidence of sexual dysfunction, no weight gain, no significant cardiac effects as well, lower incidence of withdrawal, all of these positive aspects associated with Vortioxetine. And it is a serotonin modulator, so modulates a number of serotonin systems. By antagonizing the 5-HT7 receptor, it promotes cognition. So this agent can be useful for cognition, which we covered earlier. And they simultaneously modulate one or more of the serotonin receptors and also inhibit. So there's a little bit of serotonin increasing activity, just like an SSRI. So it's an SSRI plus agent because it has these other actions, but also increases dopamine, histamine, noradrenaline, increases acetylcholine. So it's a multimodal agent. NARI, reboxetine I talked about, NARI. So basically it's a norepinephrine or noradrenaline reuptake inhibitor by blocking that transporter. So it increases levels of norepinephrine and epinephrine. NDRI, Bupropion, good agent. NDRIs are antidepressant medications that block the action of specific transporter proteins. By the way, NARI, just going back, atomoxetine, which is used in ADHD, is also a NARI. So NDRI, Bupropion, very useful agent that I've covered, can also increase levels of norepinephrine, helpful in cognition, motivation, drive, anti-smoking, activity, etc. And dopamine plays a key role in movement, affects motivation, perception of reality, ability to experience pleasure, right? So this is bupropion. As you can see, you've got NAT, which takes up the noradrenaline. You've got DAT, right, which is responsible for uptake of dopamine. And what bupropion will do is block this. It will block this, so there are lots available in the synaptic cleft. Okay, SARI, which is trazodone. They tend to prevent the reuptake of serotonin. So it's a reuptake inhibitor, RI, and it's a serotonin antagonist as well. Okay, so trazodone has antidepressant properties, but also promotes sleep. So I've covered antidepressants. It's quite an exhaustive sort of topic, isn't it? And it just sort of shows that psychopharmacology is absolutely crucial when considering treatment. This is not about just a hit and miss. People often talk about antidepressants as trial and error. Not really, because by understanding the psychopharmacology, by really carrying out a good clinical assessment, by understanding the symptoms that the patient has, one can choose, consider the right antidepressant for that particular patient. And this is the power of psychopharmacology, without which it's very difficult to appropriately treat psychiatric disorders. So I hope that you found this video educational and helpful. If you liked it, leave us a like. Don't forget to subscribe to our channel as well. And I really appreciate you supporting this channel, and thanks so much for watching this video. I look forward to seeing you in another edition of Hub Bites. Until then, take care and stay safe. Bye-bye.